All right, we'll let people continue to kind of jump in here, but for time's sake, I think we should get started. That way we can cover everything that we want to cover. Um, we appreciate you guys coming in on a Saturday. You know, we have people from all over the world on here. So whether it's morning, evening, or night, we appreciate you joining us. For some of you, this may be your first experience with us at ICANN. So for those of you who don't know us, my name is Kyle Paxton, and then we have Ryan Foley here as well. We're both the co-founders of ICANN. We'll be the ones kind of taking you through this masterclass here. This is an idea of something that I think we probably want to do more of, give people more of an insight into not just what we do and kind of how we think with our framework, but how to apply it into a more specific diagnosis or area of clinical treatment that I think a lot of us or a lot of people have been asking of us to be able to give some more insight there. So hopefully we do more of these. The way all of these recordings usually go is we'll leave the chat open for questions. So if you have questions as we're going through slides, feel free to throw them into the chat. I'll read them out loud so that way we can get them on the recording, and we'll kind of answer them as we go. If they really start to back up, we'll try to get some breaks to answer more questions. And then at the end, if we have time, we'll also have some opportunity for questions where we can unmute people and they can talk and ask their questions out loud. But for now, as we get started, ask questions in the chat. And I encourage you guys to be active, right? One of the benefits of being live is being able to ask questions. We really appreciate when you guys do. That's going to allow us to clarify what we're talking about. So don't be afraid to use the chat and ask away. And then recording, again, this is all being recorded. So please make sure your mics are muted. We'll unmute you if we need you to talk for some reason. Otherwise, the recording will be edited up and we'll email it out to everyone within the next 24 hours or so. So you guys have that. The recording will be available to watch for the next 7 days. So if you want to go back through it, kind of pick it apart, take some more notes, you'll have the opportunity to do that. If you guys don't have any other questions, Ryan here will go ahead and take it away. If there's any technical issues, if for some reason someone's glitching or Mike is having an issue, please let us know in the chat so we can fix it as soon as possible. Cool. All right, Ryan.
Okay, perfect. Hey guys, thanks again for joining us on this Saturday. So I'm just going to jump straight into it. Okay, so what I want to highlight before we get into the actual objective and subjective portion of this is the way we're organizing our approach towards low back pain here for this masterclass is looking at how the low back as a whole and how it interacts with the lower limb manages forces. Okay, so we're looking at more the neuromechanical element of it, but we do have to appreciate that there are psychological and social elements to the experience of pain around the low back as well. But just to keep it streamlined and within a more of a neuromechanical approach, we're going to look to see how the system is managing forces. Okay, so looking at things through a neuromechanical lens, and this really has its place in more of a dynamic systems approach as well. Just block this off here. So when you use a dynamic systems approach to guide your assessment and your treatment process, this you have to characterize your treatment through an interaction lens. You have to look at interactions, okay? Interactions between muscles and joints, interactions between different body regions, interactions between the body and the environment. So looking at interactions allows us to discuss the role of different regions of the body within the context of how well they can manage forces and how well they can distribute forces. Okay, so the first interaction we're going to look at here within the context of the low back is the interaction between the nervous system, the anatomy, and the environment. Okay, so the nervous system obviously interacts with the anatomy. It uses the anatomy as a vehicle to interact with the environment. And the environment interacts with the anatomy in the sense that the environment is what places the forces on the anatomy, and we have to respond to that. So we can look at it in two ways. We can look at it through a distal to proximal lens or a proximal to distal lens. Okay. Now, what we'll get through in the next slide as well is looking at more of a constraints theory based on Carl Newell's work, in the sense that a more global interaction is looking at the interaction between the person, the task, and the environment. Okay, that's more of a global interaction. But what we need to do first, particularly when we're looking at a local pain experience, we need to look at local interactions or interactions within the anatomy, and then look to the environment and the tasks. So first here, we're looking at the interaction between the neurology, the anatomy, and the environment through a distal to proximal and proximal to distal lens. Now, a distal to proximal strategy, you can look at it in a couple of different ways. If you're looking at it from a muscle and joint, or through a muscle and joint lens, it's looking at the capacity for the distal tissues to dampen load, acting on it from the environment, and then distributing that load proximally. And looking at things from a proximal to distal lens, you're looking at how well the anatomy as a whole can act on the environment. Because what we'll get through as well is we'll look at the muscular features and the joint features of the midline versus the lower limb within the context of low back pain. And one thing that we do have to appreciate as well is that the majority of our muscle mass is distributed proximally around the midline regions. Because if we had a lot of muscle bulk distributed around our distal extremities, around the hands and the feet and the foot and the ankle, then that wouldn't allow for the foot and the ankle, which is more relevant to the lumbar spine. It wouldn't allow the foot and the ankle to be very responsive to the forces acting on our anatomy. So because we have less muscle mass distally at the foot and the ankle, what this does is allows the foot and the ankle to be very responsive. But one of the things to consider here is that if we lose those capacities to manage force as well at the foot and the ankle, then the more proximal structures may have to take on a different role. Okay, so we have two strategies here. So these distal to proximal strategies considers more how the environment acts on the anatomy and how the anatomy should behave to manage those forces acting on the anatomy. A proximal to distal strategy is more so the anatomy acting on the environment. So how can I overcome forces? Okay, one of the key goals within our approach is the importance of restoring distal to proximal capacities first before we restore proximal to distal capacities. And we'll get into that in much more detail as well. Just going to bring this down here, make it easier. That's not going to work. Okay. So looking again more distal to proximal features, it's the environment acting on the anatomy, which then will influence the behavior of the neurology. If you look at it from a global perspective as well, we have two different strategies from an individual perspective. We can either control forces or control disturbances acting on our system and distribute forces over broad surface areas. Or what we can do is we can produce forces and act on the environment. So a distal to proximal sequencing of behavior involves the capacity to manage forces acting on our system. And again, like I said before, a proximal to distal strategy is when we're acting on the environment. Okay. Another key thing to consider here is the organization of your musculoskeletal apparatus. It's designed in such a way to help our anatomy as a whole manage forces acting on our anatomy from the environment first. That's why we have less muscle mass distally and more muscle mass proximally. Okay, because less muscle mass distally reduces the inertia of the distal segments, which allows them to move at speed and which allows them to actually be much more responsive to the forces acting on our system. Okay, this distal to proximal and proximal to distal lens will become much more important and much more understandable as we move into the PowerPoint as well. One of the key things when we're working with low back pain is we want to establish an endpoint goal. What would represent that our low back is robust and able to handle forces and handle stress? Globally, we need to look at the interaction between the midline and the lower limb first. So the low back, the pelvis, the rib cage, for example, these are proximal segments. They don't interact directly with the external environment, but the distal tissues do. So we want to consider the distal tissues as well within the context of a back pain experience, a low back pain experience. And when we're establishing an endpoint goal, we need to appreciate that there's two overarching goals of an individual when we're actually working with our system. There's a nervous system goals, which are all based upon protection and robust movements. So our nervous system wants proof that our system can manage force as well. Okay, the nervous system is constantly estimating the capacity of our anatomy to manage forces acting on our system, so that it can alter its communication with the anatomy to ensure that we have the capacity to manage those forces appropriately. Okay, and this is again guided by the key neuromechanical design of the movement system, how we have a difference in muscular and joint features distally and proximally. Okay, so really important to consider that. And that's different to the what we call the cognitively generated goals of the client. So a client might come to see you with a low back pain experience, but they may have different goals that are meaningful to them. Two people might have the same low back pain experience, but person one might need to play with the kids in the ground pain-free. Person two might need to carry out manual labor tasks at work. So they have different cognitively generated goals, but the nervous system goals remain the same. And we can use those nervous system goals to actually guide our assessment and to guide our rehabilitation as well. So when you look at this interaction here, this is this interaction I was talking about globally based on Carl Newell's work, a constraints approach to rehabilitation and to movement, where we have this interaction between the individual, which we are going to add subcategories to, where we look at the neural features, the muscular features, the joint features, and the attentional features. So the individual needs to interact with the environment, the demands of the environment, and they need to interact with the demands of the task as well. So different tasks will facilitate different behaviors. So for example, if I go back up here and I go through this video quickly, just to give you an example of what I'm talking about here. Within the context of proximal to distal and distal to proximal sequencing, when we're managing forces acting on our anatomy, typically this is biased towards tasks that are more disturbance control biased, or managing forces and absorbing forces acting on our anatomy, which is a little bit more flexion dominant. So when we have this athlete here drop, what we're going to see is we're going to see this flexion moment of the joints across the lower limb. So you're going to see that here again. We're taking the ankle, the knee, and the hip through extension first. Then we're dropping into flexion of the ankle, flexion of the knee, flexion of the hip and the pelvis. Okay, the flexion moments here allow us to distribute the forces acting on our anatomy over a broader surface area. And then on the other end of the spectrum, we have a proximal to distal sequencing, where we're producing force on the environment, so on the ground here, where you're going to see this sequencing of the hip to the knee and to the ankle extension. So we're going to see this proximal to distal sequencing of extension through the system. So you'll see that hip extend, the knee extend, and then the ankle extends. So you'll see that hip extend, the knee extend, and the ankle extend. Now, on the other end of the spectrum, we're going to see this flexion typically from distal to proximal, but it's a little bit different in this strategy here because we're delaying that impact force of the foot with the ground here to challenge the isometric capacity of the hip and the knee in this scenario. So don't worry about that for now, but just notice that from a distal to proximal standpoint, it's going to try to distribute flexion into the anatomy, and a proximal to distal, from a proximal to distal standpoint, it's going to try to distribute extension into the environment so that we can act on the environment. Okay, this will be important when we look at the objective assessment. So when we're looking at the interaction between the individual, the environment, and the task, the strategy that the individual will use can be described through a more proximal to distal or distal to proximal lens, but it's based on the task. So the task is more force absorptive bias or force absorption bias task. Then we want to utilize more of a distal to proximal approach. If we're trying to propel our bodies forward or to produce force on the environment, it's going to be more a proximal to distal type strategy and bias strategy. Where that becomes important in the context of low back pain is that we want to ensure that distal tissues have the capacity to dampen those forces distally so that the proximal tissues don't have to express a different behavior or excessive workload to manage those forces. Okay, so we're looking at this on through a coordinative lens. Okay, because if the distal tissues lack the capacity to manage those forces because of their unique organization, the unique architecture of the distal tissues, the unique muscular arrangement of the distal tissues, they're better organized to manage those forces. The proximal tissues aren't necessarily designed to manage those impact forces acting on our system. Okay, so we need to consider, within the context of a proximal pain experience at the low back, we need to consider both proximal features and distal features. Okay, but again, firstly, considering that the nervous system has its goals, they're biased towards protection. The individual, the unique individual that you're working with will also have their unique goals as well, that are biased towards what's meaningful to them. Okay, they don't care about protection necessarily, but we need to run the nervous system goals and the client's cognitively generated goals in parallel with each other across the rehab plan. Okay, and we can separate these features that would represent good, robust protection of the anatomy against forces through these 4 different layers. So neurologically, we can look at the difference between conscious versus subconscious control. We can look at the difference between feedback and feed-forward control. On a muscular level, we can look at the difference between proximal muscular behavior and distal muscular behavior. For example, when you look at the glute max, for example, this is a muscle that has long parallel fiber arrangements with not a lot of tendinous tissue. So this tissue is biased towards expressing more concentric and eccentric behavior. Whereas when you look at the distal tissues, look at the gastroc and the soleus, for example, the fiber arrangements here, they have much more shorter fiber lengths, and the fibers arrange at an oblique angle into a long free tendon, the Achilles tendon, which means that because of the fiber arrangement here and the short fiber lengths, these tissues aren't designed to necessarily act in a manner that tries to get the muscles to express large movement excursions. We want the tissues to bias more isometric behavior so that the tendon can lengthen and shorten. So it's not the muscle that lengthens and shortens. The capacity for the gastroc and soleus to work isometrically gives the tendon the capacity to lengthen and shorten. And that allows for the distal tissues to manage those forces well. So you can imagine if we lose the capacity to dampen force as well and express those behaviors distally, then we may have to increase or change the behavior of the proximal structures now to take on that workload or that role of the distal tissues. And that's where we might get into some difficulties with allowing the system to be robust, because again, we need diversity across the lower limb and across the midline. We can't have the proximal structures taking on the same workload or the same role as the distal structures. Okay. Looking at the difference between monoarticular tissues and biarticular tissues, for example. Again, biarticular tissues are designed to transfer forces over broad surface areas. Monoarticular muscles are designed to concentrate forces and express more eccentric and concentric behavior to produce force. So again, looking at the design of the anatomy and the muscles in particular can help us guide, well, what kind of behavior, what might we want to facilitate through those tissues, okay? On a joint level, and we're going to look at this in much more detail in this PowerPoint here, the interaction between segments is very, very important within a dynamic systems approach. We have different ways in which the joint segments can interact with each other to enable a wider range of movement possibilities to manage forces. If, for example, if we look at the rib cage and the pelvis, for example, if the rib cage and the pelvis are moving in the same direction at the same time, this would demonstrate more of a freezing strategy or an in-phase pattern based on coordinated research. If those segments are moving the same direction at the same time, you're not getting any length changes in the tissues that connect those two segments. Okay, so again, you're reducing the movement possibilities between those two structures. Whereas an anti-phase pattern is when the segments can express movement in opposing directions, and this is traditionally kind of looked at as dissociation behaviors. Okay, which we'll get into as well. An attentional feature is, where are you distributing your attention? Are you distributing your attention externally, or are you distributing your attention internally? Okay, so one of the endpoint goals that we want to reflect that our system is robust, even in the context of low back pain, is good, robust locomotion from an unsteady standpoint. So this is a good research paper to look at here: unsteady locomotion, integrating muscle function with whole body dynamics and neuromuscular control. Because what it does is it looks at the behaviors of the lower limb within the context of the behaviors of the midline, and how the lower limb can take on a role to dampen forces acting on the anatomy, while the midline expresses more adaptability. Okay, so we're looking at classic kind of hopping strategies here. So you're going to see this hopping strategy, the submaximal hopping strategy with a horizontal bias. You're going to see most of the load dampened distally, so you're not going to see a lot of movement excursion at the knee and the hip. So again, this type of hopping strategy would reflect that the distal tissues have the capacity to manage load distally, while the proximal tissues have the capacity to express less co-contraction or less in-phase strategies. It doesn't mean you have to work to this in every single low back pain case scenario, but again, by using this as a representation of an endpoint goal, we can organize the lower limb, we can organize the midline in a certain way. Okay, and then we can change the behavior of the proximal tissues as well. So for example, we can add more of a flexion bias to the midline by hugging a medicine ball or hugging a lighter ball, adding a little bit more flexion moment. As we increase the challenge distally, we can add more of an extension bias at the spine. Because what you'll see here is, as we get into the into some of the interventions, is that one of the key things when we're working, particularly when we're using an IKN approach with this stuff, is that a lot of the times we want to manipulate the behavior of the midline as we increase the low capacity of the lower limb. Okay. Now, obviously, this is not something you're going to be doing with clients day one or in the early phases, but this is almost what you want to work towards, to reflect that the lower limb can be a good lower limb, and keeping the midline quiet in a sense where the lower limb can actually manage those forces. This is a graphic that we use oftentimes with clients to reflect a better relationship with stress almost. So if you look at stress and load on this end of the spectrum and time on this end, what it does is it gives us an understanding of how we need to change our relationship with stress within the context of a protective threshold. So if you imagine when stress builds to the point where it reaches this protective threshold, when we tip over this threshold, this is when the nervous system may feel the need to express higher levels of top-down protection. This is when the nervous system may feel the need to express pain or changes in muscle activity to protect your system, okay? And it's also good to help particularly clients with low back pain understand that just because we have a pain experience, that doesn't necessarily mean that we've done any damage. Your system will express those levels of those features of protection first before we do any damage. So what we want to try and do is we want to try and bring the client's capacity below that protective threshold. So this blue line represents the stress here. What we want to try and do is change the way that the individual is managing stress to build more robustness. So if we can walk them down this staircase here, and we can open up a safety margin. So if we bring them from here to here, then we open up this safety margin where they can handle more stress before they tip over that protective threshold. Because you'll often see these graphics with the steps going in an upward direction. But I think this one here, it highlights the importance of constantly improving your body's capacity to manage forces and manage stress. Okay. Into more of a neurological understanding here. When we're looking at the behavior of the lumbar spine, for example, we want to look at this within the context of neurological interactions as well. So one of the key interactions that we need to look at is the interaction between the cerebellum and the cortex. So the cortex is the higher part of the brain, and this is the part of the brain. We're just going to go through a little bit of neuroscience here, nothing too major. So the higher part of the brain, the cortex, is the part of the brain that actually produces motor output. But the thing about the cortex is that when it produces a motor output into the tissues, into the muscular tissues to act in the environment with managed forces, it's very unspecific motor output. Okay, what we need is the cerebellum to refine that motor output and improve the coordination of muscle activity. So what you'll see oftentimes in individuals that have cerebellar diseases or any kind of disruption with the cerebellum is you'll see there's a very jerky movement. So they're able to produce force, but they're not able to refine that force. Where this becomes important for us within the context of a midline pain experience is the spatial organization of the cerebellum. So the midline portion of the cerebellum here, this is the cerebellum here, the midline portion of the cerebellum is the part of the cerebellum that represents more midline structures. So structures across the midline, the head, the rib cage, the pelvis, and all the associated muscles. As we move from medial to lateral, then we actually get into the spatial organization of more distal segments, okay, into the shoulders, the elbows, the hands, into the hips, the knees, the feet, and the ankles. Where this becomes even more important is understanding that the more distal parts or lateral parts of the cerebellum interact more with the cortex, whereas proximal structures of the cerebellum interact less with the cortex. And this means that the cortex biases more attention or conscious control through the distal portions of the anatomy. Okay, and that will change how we organize our assessment and our rehabilitation strategies, because instead of just hyper focusing the interventions directly to the low back, we need to look at how the foot and the ankle is managing forces within the context of the behavior of the low back, because this is how the cortex and the cerebellum cooperate to express motor activity, to interact with the environment Okay, I don't want to go too deep into the neuroscience, but just to give you a very general insight there. So we're coming up to the objective assessment now. But again, just wanted to give you kind of an insight into some of the features that guide our approach to the treatment of low back pain. Okay, so we need to look at local and global features of the anatomy. Locally, we're looking at the coupling between joint segments. Okay, so we're looking at the interaction between the rib cage, the pelvis, because really the lumbar spine is really a reflection of how the rib cage and the pelvis interact with each other. Okay, when the rib cage flexes and the pelvis extends or posteriorly tilts, that will facilitate more of a flexion of the lumbar spine. When the rib cage extends and the pelvis flexes or anteriorly tilts, this is going to facilitate more of an extension of the lumbar spine. So instead of trying to look at the relationship of different vertebrae, if we look at the interaction between these bigger segments and how they couple with one another, we can really try to express and organize better interventions that allow us to move from proximal to distal, because that's one of the key things that we're going to work towards in the interventions. We're always going to move from proximal to distal when we're working with low back pain, but the goal is to restore good distal to proximal load sharing qualities. Okay, and then we're looking even further distally into the interaction between the pelvis, the femur, the tibia, the foot and the environment, but mainly through a global perspective there. Because so we have these local interactions, but we also have these global interactions. So we can look at the interaction between the ribcage, pelvis, femur, tibia, or on a global level, we can look at the interaction between the midline as a whole and the lower limb as a whole. This is a really important distinction because very often the knee-jerk reaction is to always narrow the focus in on the low back and look at the interaction between the ribcage and pelvis and forget about the impact of the lower limb. But at the beginning of the objective assessment, what we want to do is we want to move from the global to local. So when we're doing our initial assessments, we need to look at, okay, how is the midline behaving within the context of the lower limb? What does this behavior mean within the context of how the lower limb is managing forces? Does this mean the midline needs more direct work, or does the midline need less work and the lower limb need more work? Okay. And we're going to get into the ribcage pelvis interactions. We're going to get into muscular behaviors as well as we get into the interventions in a few moments. But it's really important to consider these local and global interactions because they run in parallel with each other from a rehab perspective. So you're always going to do global work and you're always going to do some local work when you're working with low back pain. But the amount of local work will depend on the unique measurements, the unique experience of the client. Okay, and we'll get into some specific case scenarios in the next few slides as well. Looking into the subjective assessment as well and how we can use the subjective assessment to guide what we might need to do. Looking at past injuries is really one of the key things that we need to use to guide whether we need to do more direct work or local work around the lumbar spine, or if we need to look globally at the midline and lower limb interaction. So how might a past injury influence the strategies that the nervous system will use to interact with the anatomy? Okay, so we're looking at midline versus limb. So let's say, for example, we have a client with a current pain experience at the lumbar spine, but when you dig into their past injury history, they have had no major direct injuries or major pain experiences in the lumbar spine in the past, but they have had a history of lower limb injuries, foot and ankle injury or knee injury, for example. That's going to help direct you towards the what's going to happen at the beginning of the rehab process and where you might need to take the client from a rehabilitation perspective. You may also have a client where they have a lot of low back pain, but when you dig into the past injury history, they've had midline pain experiences and midline surgeries, for example, or intermittent low back pain, where they've had direct trauma to the low back from the surgery. They might have had a fracture to the rib cage. They may have had a concussion and no distal injuries, no issue, no previous ankle sprains, no previous knee injuries, for example. In that scenario, you may have to do more work to the low back before progressing distally. Okay, you're always going to progress from proximal to distal, but the speed at which you progress from proximal to distal will depend on the unique experience of the client and what you find during your objective assessment. Okay, so how quickly can we progress from distal, progress to distal loading from proximal to distal? Okay, so remember, within the context of low back pain, we're always going to work from proximal to distal, but how fast we move from proximal to distal will depend on the unique client. And this is really, this picture here is how we kind of organize it clinically as well. As I draw a stick figure and I mark out where the client has had past injuries. So I can use this representation to have described to them how maybe a history of an injury at the lower limb may affect the behavior of the lumbar spine, for example. Okay, so it's good to see more of a body location expression or representation of how past injuries, how current pain experiences may influence how the anatomy as a whole can distribute forces. Okay, and this study here is a really nice study. The low back pain status affects pelvis and trunk coordination and variability during walking and running, because what they do in this study is they look at the interaction between the pelvis and the trunk, and the pelvis and the rib cage, really the pelvis and the thorax, in runners with a current experience of low back pain, in runners with no low back pain and no history of low back pain, and in a third group in runners that don't currently have pain but have a history of low back pain. And what they found is that in runners with a current experience of low back pain, they demonstrated more in-phase strategies between the rib cage and the pelvis. And remember, if we go back to what I mentioned before, these in-phase strategies are more freezing strategies based on the work of Bernstein. This demonstrates that the pelvis and the rib cage don't have the capacity to move in opposing directions. They move in the same direction. So this limits any kind of joint angle changes and muscle length changes, which makes it easier for the nervous system to protect the anatomy, but it sacrifices your adaptability. And in the other group, in runners with no low back pain, no history of low back pain, they demonstrated more anti-phase patterns between the rib cage and pelvis, more freeing strategies based on the work of Bernstein. So the pelvis and the rib cage were able to move in opposing directions, which means that the muscles have the capacity to go through a wider movement excursion. The joint angles can change, which means that you have more options to distribute forces over a broader surface area. When you have more in-phase strategies, you tend to concentrate load into one area. When you have more anti-phase strategies, you can distribute forces over a broader surface area. And in the third group, in runners with no current experience of low back pain, but a history of low back pain, they actually sat right in the middle. So they still demonstrated some in-phase strategies, but not too much in-phase patterns. Okay, so this actually is really interesting, because we can use this representation of how the joint segments interact to help us understand how the nervous system is distributing control across the anatomy. Because you always hear, especially in the low back pain, in low back pain experience, you always hear people talking about clearing certain joints, clear the hip, clear the knee, clear the ankle. This gives us a framework to help not necessarily clear a joint, but just to see how well that joint is distributing forces within that joint complex locally, but also we can step back and understand, well, how is that influencing the capacity of the lower limb to manage forces as a whole? And we're going to get into that in just a few minutes as well. So really worth looking at that study. So when we're working through the objective assessment sequence, we're moving from global to local to global qualities. And this gives us the capacity to establish multiple entry points to treatment. We're always going to assess from proximal to distal, but the global assessments first give us an insight into the general interaction between the limb and the midline. They give us a general insight into the capacity of the distal tissues to express good isometric capacities. Okay, and they give us a general interaction or general insight into how multiple joints will interact with each other. Okay, then we move into more local assessments. That's when we're looking at, so you could use a standing spinal flexion assessment as a global insight, and then you may look at more closely and narrow in at the femur pelvis interaction, for example, to see how the local tissues are interacting with each other. But if you go straight into local assessments and you use local measurements to guide your treatment approach, then you don't understand necessarily how that local interaction between the femur and the pelvis, for example, or the pelvis and the rib cage may influence how the midline and the lower limb as a whole interact with each other. So we're looking at local joint behavior, we're looking at local muscular behavior, we're using passive and active strategies to do that. And then we're going back to global strategies, but here we're looking at how well the individual can manage load and forces during the assessments. So we're not just looking at how joint segments are moving relative to each other. We're looking at how well they can manage load at the same time when we're trying to see how joint segments are interacting with each other. Because we're not necessarily introducing a lot of load and force to the system during these early assessments, but we do need to see how well those are, potentially if those joint interactions change when we introduce load into the equation. Okay, and that gives us the capacity to see how well the client can distribute load from distal to proximal. We're mainly focusing on how the biarticular tissues are managing forces as well, because those are the tissues that help to transfer forces over broader surface areas. Okay. So this will be kind of a representation of how we map out the assessment. So we're looking from proximal to distal. So we're moving from a global assessment first, which isn't really mentioned here. We're using this as more kind of a local insight or representation as well. So let's get into the assessments here.
Hey, Ryan, before we dive into that part, because I think it'll be helpful for chatting through it, can you clarify the in phase versus anti-phase one more time?
Yeah. So let me look at the anatomy. Is that a question from someone?
Yeah.
So based on the work of Nikolai Bernstein, again, I'm just going to give this background of Bernstein because he is the one that highlighted these different interactions between joint segments. So he identified that in individuals with you don't want to say inferior coordinated capacity, but novice movers, unskilled learners, they demonstrated more freezing strategies. A freezing strategy is a strategy where joint segments don't move relative to each other. So a nice kind of example to use, I don't know if you can see me there, but if you're looking at someone's neck rotation, if I'm rotating my head on my rib cage, I want the head to rotate without the rib cage moving in the same direction. So if I can move my head to the right, that means my rib cage is relatively rotated to the left. That will be an anti-phase pattern. When I'm looking at right side rotation and my rib cage moves in the same direction, that's an in-phase pattern. That's an in-phase strategy where the segments are moving in the same direction. Okay, that represents that the muscular tissues that connect those two segments don't have the capacity to go through the appropriate length changes. Okay, so an in-phase pattern makes it easier for the nervous system to control forces, because it means that you have less movement possibilities. More movement possibilities makes it harder to control your movement. That's why frequently in clients with a low back pain experience, they demonstrate more in-phase patterns between the rib cage and the pelvis. Because when you're experiencing pain, you don't really want a huge amount of length change and joint angle changes between the rib cage and the pelvis, because you're trying to protect those structures. You're trying to reduce the amount of stress going through those structures. So one key feature of our approach is that we need to slowly restore the capacity to express these anti-phase patterns, but at the same time, they need to be able to manage load and maintain the representation of those anti-phase patterns. Okay, so hopefully that makes sense there. Is that okay?
Perfect. Yeah, thank you.
We'll talk about it here more so as well when we're going through the objective assessment. So if we're looking at a standing flexion, spinal flexion, a toe touch assessment, for example, we can look at it from a global perspective and even a local perspective as well. So globally, if I put up that video here, globally, well, what we want to do initially is we want to make sure that the test is the same feature. So we'll always have the client place the fingertips on the anterior thigh and slide the fingertips down the front of the lower limb, because typically if you don't constrain that or if you don't make that a consistent feature of your tests and retests, sometimes the client will reach further away from the body. And if you reach further away from the body, that may change the behavior of the rib cage and the behavior of the pelvis. But what we're looking for here is we're actually looking for the client to demonstrate an anti-phase pattern between the rib cage and the pelvis. So ideally, we want the head, the rib cage, to move into flexion first. That would be the early phase. So when the rib cage flexes, we want the individual to express the capacity to delay or slow down the flexion of the pelvis. Because when the rib cage flexes, and if the pelvis maintains more of a posterior tilt or an extension early on, that gives the lumbar extensors the capacity to lengthen more, to express more eccentric behavior. And in clients with a low back pain experience, they may not want to express any kind of movement or any kind of eccentric behavior through the lumbar spine, through the lumbar extensors. So we're looking for that early capacity to delay the movement of the pelvis, particularly into flexion, because now the rib cage is flexing, the pelvis is extending. That's antiphase in the sagittal plane. They're moving in opposing directions in the sagittal plane. As I then begin to flex even further past the knees, that's when the pelvis will need to begin flexing. So now I'm into more of an in-phase pattern, because when you get into the deeper levels of understanding antiphase versus in-phase, or freeing versus freezing strategies, this whole body movement is an expression of both in-phase and antiphase. But you want structures and interactions to have the capacity to express antiphase, but in real world movement, there will be a distribution of both in-phase and antiphase, but at different times. Okay. So again, you'll see here the pelvis will begin flexing then, but it's flexing with the flexion of the rib cage, which still allows the lumbar extensors to express more eccentric behavior. If we compare that to an early flexion of the pelvis, so you'll see here. So as I reach down, you won't even see much flexion of my rib cage here, which means that, again, I don't have the capacity to facilitate that rib cage flexion. I don't have the capacity to express that eccentric behavior of the lumbar spine, of the lumbar extensors. And now my pelvis comes along for the ride very early, because I haven't given it the capacity to delay that forward flexion. Okay, so we're not seeing any lumbar flexion here at all. Okay, we're just seeing that flexion of the pelvis very early. So we're not seeing that capacity to demonstrate an anti-phase strategy or freeing strategy early on. Now, in situations like this, when we have an inability to flex the rib cage and the client has a pain experience of the low back, this might mean that we actually have to do more work through the rib cage first before we start to work through the lower limb and the pelvis. And we'll talk about that as well. What we also like to do here as well is we like to look at the difference between standing flexion and seated flexion, because in a seated position, we take out the challenge, we remove the challenge of the lower limbs to manage forces, and we're checking to see how well the rib cage and the pelvis are moving with each other. So can we see that flexion of the rib cage? Can we delay that extension of the pelvis? But most importantly as well, in something like this, how does this alter the pain experience, which is the key thing, okay? You're looking at both the joint interaction, but you're also looking at the pain experience. So as a question, and again, I'll ask this question to all of you, if the client had a pain experience at the lumbar spine during a standing flexion assessment, but they didn't have a pain experience at the lumbar spine during seated flexion assessment, where do you think the limitation is? Do you think the limitation is in the midline, or do you think the limitation is in the lower limb? Okay, that's a really important thing to consider, because in a standing position, it's challenging the capacity of the lower limbs to take on that workload from distal to proximal, which gives the spine the opportunity to lengthen, to relax all the anti-gravity tissues of the spinal extensors. Okay. Yes, so the problem is likely in the lower limb in that scenario, because now what you've done is you've taken out the challenge to the lower limb, and you're narrowing your focus on how the lumbar spine is moving relative to the rib cage and the pelvis. So if the pain reduces in the seated position, it means that the lower limb is likely the limitation. The low capacity of the lower limb is likely the limitation in that scenario. Okay. If the pain didn't change between standing and seated, in that scenario, it means that we might have to do more local work around the lumbar spine before we move distally. So it doesn't necessarily tell you exactly what you need to do, but it tells you how much time you might need to focus on the proximal structures before moving distally. Okay. And just to give you a quick insight into the opposite end of the spectrum, because it's not all about flexion. We are going to focus on more flexion behavior in this masterclass here, because it typically tends to be the one that's demonized the most. But we can also see the same thing in extension. So we're looking at standing spinal extension. What you see here is you see a flexion of the pelvis, but you also see a flexion of the rib cage, or an inability of the rib cage to extend. So what you're seeing here is an in-phase pattern where the rib cage is flexing and the pelvis is flexing. And this doesn't allow for extension to be distributed across the lumbar spine. It means that it's likely concentrated around the lower portions of the lumbar spine, compared to this strategy here, where we're extending the rib cage and we're flexing the pelvis, which gives the capacity of the abdominals to lengthen, and it distributes that extension across the lumbar spine a bit more evenly. So that's an anti-phase strategy. Rib cage extends, pelvis flexes in the sagittal plane. Okay, you'll often see that early strategy there where the rib cage will flex and the pelvis will flex. Okay, which doesn't demonstrate that the client has good anti-phase patterns. Okay, so those would be the global assessments. We're not going to necessarily go through any local assessments here, but we're going to go into more of a global loading assessment. And before we get into this, what I just want to highlight here as well is the interaction between the pelvis and the femur in a little bit more detail. So when you look into the research, particularly this study here, the sagittal plane pelvis motion and how it influences transverse plane motion of the femur, the kinematic coupling at the hip joint, when the pelvis extends or posteriorly tilts, that will couple with an external rotation of the femur in the same direction. That's an in-phase pattern. So the motion of one segment will drag the other segment in the same direction with it. So posterior tilt will facilitate femoral external rotation, and a flexion of the pelvis or an anterior tilt of the pelvis will couple in the same direction with femoral internal rotation. Okay, those are in-phase patterns or freezing strategies. What we want the client to have the capacity to do is to demonstrate anti-phase patterns or freeing patterns between the pelvis and the femur. So can the pelvis extend while the femur maintains its position or moves into internal rotation, which is particularly important when we're looking at the capacity of the lumbar spine to flex, while the pelvis and the femur can demonstrate these anti-phase patterns, which gives us a wider scope of options to distribute forces. Okay. So if we're looking at the low capacity of the limb relative to the midline, we can use what we call a loaded dissociation test here, where we're in a position in supine with the hip flexing 90 degrees, the knee flexing 90 degrees, and we're seeing can the client build pressure via the heel, via knee flexion, to facilitate the extension of the pelvis and demonstrate that anti-phase pattern between the rib cage, the pelvis, and the femur. So what we want the client to express is the capacity to flex the rib cage. And just before we get into this, actually, you are constrained here. And this is sometimes difficult for clients that can't flex the rib cage, because the spine is actually in more extension here, because you're lying in a supine position. So you have to be able to flex your rib cage on a spine that's biased towards flexion, which is quite difficult for a lot of clients to do. So just keep that in mind. And if the client can't do that, it means that you may have to make it easier for the client to demonstrate rib cage flexion first. And what it might mean is that you need to do more direct work through the rib cage and pelvis first before you move into any kind of lower limb loading patterns or loading strategies. Okay, we'll get into some of those. But what we want the client to do is to build that tension, bring all the attention into the heel, build that tension through knee flexion, so we get some load into the hamstrings, and we're using the hamstrings to facilitate that extension of the pelvis. So we're getting that flexion of the rib cage, extension of the pelvis. So we're peeling the pelvis up off the ground to keep the lumbar spine biased towards flexion. Okay. What a lot of clients will do is they'll end up squeezing the glutes to express that hip extension. So they lose the intention through the heel to do that through knee flexion. It's a really difficult thing to do when you're doing it well, because you have to keep that intention through the heel via knee flexion and use knee flexion to facilitate that hip or that pelvic extension. Okay, a lot of clients will just end up gripping the glutes and squeezing the glutes. Or what you'll often see is the knee deviate laterally. So this is a demonstration of an in-phase pattern. So what you'll see is that in order to extend the pelvis, the femur will go into abduction, external rotation, because that facilitates the extension of the pelvis. So remember, when the pelvis extends, that will couple in the same direction with the femur moving to external rotation. But we want to see how well the hamstring can handle load and distribute load through it, while we're demonstrating more of a freeing or anti-phase pattern between the femur and the pelvis. So can the femur stay in the sagittal plane as the pelvis extends and posterior tilts? Okay. If they can't do that, then the femur will typically go into external rotation and abduction. What you'll also often see here is just an inability to facilitate that extension of the pelvis. So you'll see this arching of the low back. So you won't see that peeling of the pelvis off the ground, which means that we're losing that intention via the heel to demonstrate knee flexion, to facilitate load to the hamstrings, which are a biarticular tissue, which are important to distribute load. That's why we're checking their load capacity early on. But we're looking to see, can the hamstrings actually manage load without the lumbar extensors demonstrating increased workload? What we're seeing here is we're seeing the lumbar extensors assist in the elevation of the pelvis, but we're not seeing any extension of the pelvis. We're seeing a flexion of the pelvis via lumbar extension. What we'll also see during this subjective assessment as well is we'll see the foot and the ankle demonstrate certain behaviors as well. So we often see this dorsiflexion of the ankle, which is a flexion of the ankle, and that flexion of the ankle will help to facilitate the flexion of the knee. That's key to understand. So that flexion of the ankle, what you'll often find is that it's much easier to build that tension into knee flexion when the ankle is dorsiflexed, because you have this flexion coupling between the ankle and the knee. So one assists the other. Okay. Sometimes you'll see that external rotation of the tibia as well. But ideally what we want is we want the ankle to stay quiet. And to really challenge things is we want to plantar flex the ankle and see, can they actually maintain ankle plantar flexion, which is an extension of the ankle. So the ankle is extended and we're trying to drive knee flexion, which is an antiphase pattern in the sagittal plane, which is much more difficult to demonstrate. Okay. So this gives us an idea of how well the joint segments are interacting as we're distributing load through the tissues, particularly through the biarticular tissues. And there's other assessments that we would use as well through the knee extensors, hip flexors, for example, as well.
Ryan, quick question on the assessment, since we can just skip back to like the standing toe touch. Dylan was saying, could you make an argument that the quote unquote challenge of the lower extremity in a standing toe touch is incredibly low and non-specific to other activities? If there's no active force production of the legs, could you look at it more as organizing relative to gravity in a standing position compared to a seated position?
Absolutely. Yeah, there's no force production challenge there, but it's about the balance demand. So when you look into balance strategies, you're looking at ankle strategies versus hip strategies. So what we're almost looking for here is the client to demonstrate an ankle strategy as the client perturbs the midline. Okay, so as we perturb the midline, can the midline demonstrate more of a relaxed behavior, if you like? And a relaxed behavior of the midline is when the extensor tissues can relax and not need to express too much extensor force production. So an ankle strategy will be demonstrated by the ankle's ability to manage any kind of perturbations from top down from gravity without the spine expressing that extensor behavior. So it's not really based on force production, it's based on ankle versus hip strategies. An ankle strategy is a lower effort strategy. A hip strategy will be demonstrated by increased muscle activity of the proximal tissues. So that's an important distinction to make there as well. It's that when you're looking at standing toe touch, there can be quite a balance challenge there as well, but you can also look at balance strategies within the context of distal versus proximal behaviors as well. Okay, so that was a good question. Hopefully that answers it there, I hope. You can let me know. Should we move on?
Yeah, there you go. I was waiting for him to respond.
Okay, cool.
Can you see the chat, Ryan?
No,
he says, thank you. Could respiratory strategy influence ankle versus hip strategy as well?
Yeah, so look, when you're looking at respiration, you are looking at the dynamics of the rib cage an awful lot more. So ideally, again, in that spinal flexion strategy, we need the rib cage to be able to flex. And when you look at from a breathing standpoint or respiratory standpoint, we need the client to have the capacity to demonstrate a full exhalation to facilitate that rib cage flexion, right? Which will help facilitate that antiphase pattern between the rib cage and pelvis. So you would look at it from a perspective of, okay, what can the rib cage do? What can't it do? If it can't flex, then can we use exhalation strategies to facilitate that? If we're going to extension, it would be the opposite. Can we actually demonstrate a full inhalation to facilitate that extension of the rib cage, which will allow us to demonstrate an anti-phase pattern? So you're looking at respiration within the context of how it can facilitate certain behaviors across the joint segments, and then how that can influence how load is distributed across the anatomy as well. Oops. Hopefully that makes sense. Okay, because once you get into respiration, it does make things complex. So you have to have kind of a reference point through which, at least from our perspective, through which you're describing other types of features, respiration, balance strategies, the whole lot. Okay. So if we go into feedback markers here, feedback markers, sometimes people call them KPIs. These are markers that are demonstrating to us about the progress of the client, to how they're managing forces. So how is the individual system managing stress, managing forces? Are we adapting in the manner that meets the unique goals of the client? So it's more like a test retest type strategy. We use a test retest or test intervene retest type model, but we can't just use one marker to represent the behavior or the progress. So we need to use multiple markers. So globally, we can use spinal flexion. Locally, we can look at something like femoral internal rotation. But both of those measures don't tell us about how well the system is managing forces. So we need to use more of a global loading strategy as well. So how long they're able to hold an isometric load through the hamstring, for example. How are the joint segments managing their behavior while the muscular tissues are managing that load? How long are they able to hold it for? This all gives us that insight into how the client is progressing as well. And then we also need a meaningful marker based on the client's goals. Maybe the client has difficulty getting out of the car, for example. So we need to couple all these goals together and use that to determine if the client's making progress or not, because we can't just use one feedback marker to demonstrate progress. So we can't just throw out a loading strategy or task just because it didn't improve the feedback marker, for example. We need to modify different variables, change the external load, for example, change the speed of the movement, change the time of retention, change the contractile behavior. Are we facilitating the right contractile behavior within the muscular tissue, for example? Okay. And now we're getting to intervention sequencing. So when we're sequencing our interventions, we're always working from proximal to distal, always. So we want to restore that proximal dissociation or anti-phase patterns. But the ultimate goal is to work from proximal to distal to restore distal to proximal sequencing, where the distal tissues can manage load well and give the proximal tissues the chance to express more adaptability. We want to keep the proximal tissues quiet while the distal tissues manage the impact forces from the environment. Okay, so your objective measurements, and then what you notice during the initial loading strategies during the early phases of rehab will dictate the speed of progression from proximal to distal. Okay, so we have 3 case scenarios here to kind of help describe that a little bit more. So let's say person 1 with a persistent experience of low back pain for 10 years. They have a history of 2 spinal surgeries. So there's been direct trauma to the low back. They have no distal past injuries. The pain is worse at rest and upon that transition from rest into movement. Okay. So because there's no distal past injuries, but there's a history of proximal trauma, you can say, to the spine. We may need to begin directing that load and changing the behavior of the proximal tissues first, before we go distally too quickly. So it's going to be more of a slower progression from proximal to distal in that scenario. Because typically when things are worst at rest, or that initial transition with movement, and then it gets better with movement. When something gets better with movement, typically the lower limbs are able to distribute some of that workload into those tissues and reduce the workload on the lumbar spine. But initially, when we're moving and we're in a rested position, we want the muscular tissues to be relaxed. But if our muscular tissues aren't able to relax, or if the nervous system isn't able to reduce the amount of muscle activity distributed through those tissues at rest, where it's almost looking at the strategy being used by the nervous system relative to the task demand. So if you're sitting down watching Netflix, but your muscles are behaving as if they're running a 100-meter sprint, that's not going to allow the muscles to relax very well. It's not going to give the muscles a chance to relax and restore some kind of variability within their behavior before we transition to movement. Okay. If we look at a second example, so we climbed with intermittent low back pain for 7 years, but with a history of ankle sprains, knee surgeries, it's still worse at rest and during that transition to movement. In that scenario, we have a history of distal past injuries. But again, there's still an intermittent low back pain experience there for 7 years. And again, there's still pain at rest and that initial transition to movement, which means that we need to direct more focus on the contractile behavior of the proximal tissues before we move distally. So initially, we need to do work proximally, but we also need to do work distally. But it doesn't mean that we're going to go jump into distal tissues too quickly, but we are going to progress a little bit faster to the distal tissues, because this is a scenario where we might not see a symptomatic change in the client's experience until we get that load into the distal tissues and restore the load capacity of the distal tissues of the lower limb. In a third example, we've a client with intermittent low back pain for 3 years, a history of Achilles pain, and it's worse after prolonged movement. So fine at rest, but worse after prolonged movement. So this is one of those scenarios when you could be fine when you go for a run for the first 20 minutes, but after 20 minutes, then your back starts to ache. You start to get discomfort in your low back. In that scenario, it could be a case where the lower limbs don't have the capacity to manage those loads for that particular duration. So they've lost that capacity at a particular duration. And now the distal tissues are now unable to manage those forces, and it's shifting extra workload into the lumbar spine or into the proximal tissues. So in that scenario, we still might have to do some work proximally, but we might need to move distally much faster to change the symptoms and to restore appropriate load sharing qualities. Okay, because this could be one of those scenarios where you could see a physiotherapist with a current experience of low back pain, but if the physiotherapist doesn't explore your past injury history and learns about these history of distal issues, and they're directing all the load and the treatment to the lumbar spine and the low back and the proximal structures, and there's no change in symptoms, and then it's because they've missed the role that the distal tissues need to play to allow the proximal tissues to express that variability, because the distal tissues need to manage the impact forces from the environment, right? So it's looking at that interaction between the environment, the lower limb, and the midline. Can the lower limb manage the forces from the environment to allow the midline to stay quiet, to stay relaxed? Okay. So now we're moving into the actual strategies, and we're going to go through a couple of options here. So when we're using the objective measurements to guide the actual rehabilitation, we need to have local limitations that we're going after and global limitations. So we can highlight the local limitations that we're trying to facilitate or restore. So an example here could be, okay, we're limited in ribcage flexion, we're limited in pelvic extension or posterior tilt, and we're limited in femoral internal rotation. But on a global level, we also have a lack of capacity to manage forces distally at the foot and the ankle. We haven't gone through those assessments here, but we do go through them in our level 1 course. But we've seen potentially a lack of load capacity in the hamstrings, for example, to handle load while the rib cage and pelvis express this association. You might even have a fantastic toe touch where there's this nice rib cage flexion, nice delay of the pelvic extension to go through a full toe touch. But once you get into a strategy like this and you load up the hamstrings, then they don't have the capacity to express that same dissociation behavior between the rib cage and pelvis under load. That's why you have to look at how well their system is managing forces under load. So in some scenarios, like we said there, we need to do more work directly on the pelvis, for example, directly on the rib cage to facilitate rib cage flexion first. So we have some options here. So you see the standing strategy here where we have this slight bend of the knee. We have the lumbar spine pressed up against the wall. You have the internal rotation of the humerus to facilitate that protraction or internal rotation of the scapula, because those all couple to facilitate ribcage flexion. And then we can drive some load into the foam rotor to facilitate some load into the abdominals, because the abdominals will help facilitate that dissociation as well from a proximal standpoint. So they can help facilitate that ribcage flexion and pelvic extension. And then we have this more challenging strategy here as well in the quadruped position, where we have this low humeral position as well to facilitate that protraction of the scapula, to facilitate this ribcage flexion as well, and we can get some load into the abdominals in that scenario too. before we begin to get some load into the lower limbs. Again, the goal is to get the lower limbs to manage force as well, but how we get there depends on what you find during the objective assessment. So these are some ribcage flexion options, and then we want to try to restore the capacity for the pelvis to extend. So we can choose a hamstring loading option here as well. So we're going to give you some examples here. So we like to start with more isometric capacities here. All right. So we like to have the client to at least get to about 60 seconds of an isometric hold in this position here, with the knee at 90 degrees, hip at 90 degrees, load through the heel, but demonstrating that dissociation between rib cage, pelvis, and femur. Once we can hold it isometrically, then we want to think about, okay, how can I actually perturb that capacity now? So if if pelvic extension or the posterior tilt of the pelvis is a limitation, and I can use something like this to facilitate it. So I have this opposing more flexion to help facilitate that lumbar flexion and pelvic extension or posterior tilt. But now I want to begin perturbing that. I can perturb that through the muscles, and I can perturb that through the joint segments. So one way I can perturb it is actually by moving from an isometric strategy to more of a dynamic movement strategy. So now I'm still loading the hamstrings, but now I'm taking the pelvis through a greater range of motion, which challenges its capacity to maintain that dissociation behavior between the pelvis and the rib cage. So you're still driving that load to the heel, still getting load to the hamstrings, but now we're not holding it as an isometric anymore. Dynamic muscle length changes challenge the capacity of joint segments to maintain a certain interaction with their neighboring segments. Okay. What you can also do as well is we can challenge the capacity to express knee flexion. So like I said before, we will often see dorsiflexion of the ankle. To facilitate that knee flexion, we can add plantar flexion of the ankle to make it harder to distribute flexion through the knee, which will make it more challenging for the hamstrings to express that load, okay? And we can add this as an isometric, or we can add as more of a dynamic loading challenge as well. And lastly, what we can do is we can maintain that position in a hamstring loaded position. We can extend the opposing knee to give room for the femur to move into internal rotation. So this will be an internal rotation perturbation. Because remember what we said before about the interaction between the pelvis and the femur. Sagittal plane motion of the pelvis and the transverse plane motion of the femur. When the pelvis extends or posteriorly tilts, that will couple with an external rotation of the femur in the same direction. So if we are trying to maintain that pelvis extension and challenge its capacity to maintain that position, then we can drive the femur into internal rotation adduction to challenge that capacity. Okay, so we're trying to perturb the maintenance of the pelvis. So you'll see that dynamic internal rotation adduction of the femur here, but we want to maintain that pelvis extension. Okay, it's really important. It's a really important kind of mindset shift in a way, because we're not necessarily always trying to restore new movement strategies, but we're trying to disrupt the current strategies that the client's using. That's why we have to have these local limitations that guide what we're actually using from a rehabilitation approach. How can we perturb this even more so? So we can start to add more of a distal challenge. So now I can start to move that femur into a little bit more extension. So instead of having the femur at a 90-degree angle, the knee at a 90-degree angle, I can bring the femur into more extension, which is going to make it more difficult to keep that pelvis in the posterior tilt or an extended position. Because as that femur comes into extension, it's going to typically want to drag the pelvis into more flexion. What I can also do is I can add more of a distal challenge via adding more of a joint torque via the ankle. So I'm adding a plantar flexion challenge here. And all I'm doing is I'm trying to maintain that isometric behavior of the foot and the ankle, and see, can I still demonstrate that ability to posterior tilt the pelvis and then peel that pelvis off the ground to keep that lumbar flexion behavior, okay, and still get that load. I'm obviously getting more load into the glutes here, into the proximal hamstrings, and then we can further challenge that by bringing the knee into extension. So the knee is staying flexed 90 degrees here. The joint that we're changing, or the interaction we're changing here, is the interaction between the femur and the pelvis. So you will see that as a way, or I want you to see that as a way to further perturb the behavior of the pelvis, okay? If that pelvic extension is a key capacity that you're trying to improve. Once we can express it, then we want to perturb it, then we want to challenge it, because then we know that it has the capacity to maintain its behavior as we increase the challenge, both distal and proximal. And this is a distal challenge here. So now we're adding a plantar flexion component to the knee flexion, to the hip extension component. So it just adds a little bit more coordinated challenge across the lower limb. Okay. Again, this is another good paper here as well, variations in balance and body sway in middle-aged adults, subjects with healthy backs compared to subjects with low back dysfunction. What they found in this study is that clients with persistent experience of low back pain struggled to distribute that load capacity into the distal tissues, into the ankle. They struggled to express an ankle strategy and consistently use more of a hip low back strategy to manage their center of mass relative to gravity. And even further on top of that, once things became even more persistent, they actually began to use more of a visual dominant strategy, where they struggled to dissociate the eyes from the head, and the whole midline segment began to move as one entire unit. So there was no antiphase, no freeing strategies across the whole midline because of this lack of capacity to express a good ankle strategy. And now we're moving into standing strategies. So when we're getting to standing, we're thinking about, okay, do I need to maintain the position of the pelvis as I challenge proximal, or do I want to continue to perturb the distal tissues as well? So an important concept for us is, particularly in clients that have persistent low back pain issues, we typically want to allow them to pre-position the low back into the direction of their limitation first, and then perturb around it. So we might perturb distally before we perturb directly. So it's this concept of direct perturbation or indirect perturbations. Okay, so we'll see in this first strategy here, what we're ultimately trying to do here is we're trying to facilitate that flexion of the rib cage, delay that flexion of the pelvis. We're getting more flexion at the knee and the ankle here to reduce that need for the pelvis to flex. And by getting that load into the forefoot, keeping the heel hovered, we're challenging the capacity for the ankle plantar flexors to express isometric behavior and increasing the load of the knee extension mechanism here as well. So you'll see that we won't go through the full range of knee extension. So you'll see that small little heel hover, that support in front, we're keeping that slight flexion bias of the spine here. As we extend, we want to get to there, because this is more of a vertical translation of the spine. When we translate the spine vertically, what we need to consider is that in order to get full hip extension, we need that knee to come back into extension as well. But the thing here is that if that knee goes back into extension, we're going to lose that forefoot load. If that knee goes back into extension, it's going to distribute more load into the heel. So we're going to lose that plantar flexion torque. Okay, that's why we're not going through full hip and knee extension here. It's more of a shorter range. So you'll see that challenge at the ankle and the knee, but we're using the ankle and the knee to perturb the behavior of the midline, keep the midline flexed, challenge the ankle and the knee. Okay, and then later strategies, what we would do then is we'd actually kind of move from this kind of third degree knee flex position and try and drive more knee extension and hip extension, okay, in a later phase. But this just allows us to keep that spine biased towards flexion. So at the end here, you're going to see what happens when I lose that force production through the metatarsal heads. That knee is going to go back into extension. I'm going to lose that forefoot contact, so I'm going to lose that distal isometric behavior. And again, I'm not going to challenge the knee extension components. So I'm trying to keep that load distally, the knee and the ankle here, and reduce the extension behavior of the lumbar spine. So increase extension at the knee and the hip, reduce extension behavior at the lumbar spine. Okay, so you'll see that load go back into the heel here if we don't keep that knee flexed. Okay, what we can also do with clients here is we can manipulate the direction of the force output, and we can obviously add kind of external load here as well. But sometimes what we have to do is, instead of adding more of a vertical translation of the midline, we can add more of a horizontal bias. Because when we drive load vertically and then add a horizontal bias to it, it makes it easier for us to keep that load into the forefoot. Instead of going vertically where the knee will want to extend back too quickly, and it'll shift that workload from the forefoot into the heel. By going upward and in more of a horizontal direction, it helps us keep that load into the forefoot, so we can maintain that plantar flexion torque, maintain that low through knee extension, and bring that hip through more extension as well. Okay, so we allow the knee to go through a little bit more extension here without sacrificing the ankle force production, the ankle torque here as well. Okay, so those are indirect perturbations. Okay, now we want to then come back and directly perturb the lower back. Okay, so now we can use a strategy where we're actually bringing the pelvis and the spine and the rib cage through motion while we're keeping the ankle and the knee biased towards more isometric behavior. So we're maintaining the position of the foot and the ankle here. We're maintaining the position of the knee, and now we're moving the rib cage through flexion, delaying that motion in the pelvis again, so that we can allow for the lumbar spine to maintain that flexion behavior. We're going to feel a lot more load in through the glute in this scenario, but we should also feel a lot of load down to the ankle extensors as well, the plantar flexors. Plantar flexion is an extension of the ankle. But the key thing I want you to understand here is that this is more of a direct perturbation to the lumbar spine versus the other strategies that were more indirect perturbations to the lumbar spine, where we're pre-positioning the lumbar spine and then we're manipulating the behavior of the more distal segments to challenge the maintenance of the proximal tissues. Okay, we eventually want to come back and directly perturb. This is really important, especially in clients with a pain experience at the lumbar spine. Very often they're expressing too much protective behavior at the lumbar spine to directly perturb it. So if we can pre-position it and then perturb distant segments at the foot and the ankle or the knee, then we can allow for a perturbation challenge to the pelvis and improve the capacity of the system to distribute load across the entire lower limb while still maintaining some uniqueness of the treatment towards the client's specific limitations. Okay, and what we eventually want to do as well with clients is you want to work towards those hopping strategies if we can. You're not going to work through them in every single client, but what we want to do is we want to work towards driving some impact forces through the lower limb. So this is a nice strategy here where we can still bias that extension of the pelvis, that flexion of the rib cage, and start to add more of a higher speed challenge to the foot and the ankle. So now we're adding impact forces to the foot and the ankle, challenging the ankle at higher speeds, but maintaining that flexion behavior of the lumbar spine as well, before we move into more plyometric strategies with the client too. Okay, so this supine plyometric strategy just allows us to do that. So we can have the knee a little bit more extended to facilitate that plantar flexion. We could even bring the knee into more extension here to make it easier for the client to express that lumbar flexion here too. But again, in all the other strategies, the thing that was missing was impact forces. And that's something that we need to deal with in the external environment, particularly if you want to get back into an activity like running. Okay, we need to improve the capacity of the lower limb to manage impact forces and keep the midline tissues quiet, keep them relaxed, maintain anti-phase behavior proximally, while the distal tissues manage the direct impact from the environment. And that's exactly why I kind of show these hopping strategies here, because they're obviously higher level strategies to manage that collision with the ground, where the distal tissues are managing the forces on their own, and we're not seeing any kind of excessive knee bend, not necessarily excessive knee bend, but we're just not seeing any knee bend or hip flexion at all. So those proximal tissues aren't being asked to express more workload, because we're concentrating that load distribution, that capacity to manage forces at the ankle on its own, without the proximal tissues expressing more workload. Okay, so some key concepts in there, but hopefully that gives you a better understanding of how we might use the neurology, how we might use the muscular tissues, how we might use the joint segments, and how we might also change the attentional focus during rehabilitation as well. I think one of the biggest takeaways that I want to get across to you is this idea of direct versus indirect perturbation. If we have a current pain experience around the low back, then you don't always want to directly perturb the low back straight away, but you may want to pre-position the low back into the direction of limitation that you're trying to restore, and then challenge global load sharing qualities or more local load sharing qualities distally or even proximally to the low back as well, before returning to more direct perturbations of the lumbar spine. Okay. So I think we can, do you want to open up some questions?
Yeah, I was going to say, so I know we're over here, so we'll answer these two questions that are already in here, but we'll just kind of work backwards through the two. First one is, more directly talking about these drills, how will these drills where we're trying to disturb and change the movement strategies of the client translate to real world movement where they're not consciously controlling those anti-phase positions of the proximal structures?
But that's exactly why we're moving from proximal to distal, because it allows you to distribute more conscious attention into the distal tissues more. So early on, you're bringing more conscious awareness into the maintenance of anti-phase strategies proximally. And then you're moving further and further distally, distributing that attention distally. And then once you get up into those, like in this strategy here, for example, I'm not thinking about the behavior of my rib cage and pelvis. I'm consciously thinking about the foot and the ankle behavior. But then even further from that, we want to distribute that attention into the external environment. Once you start to distribute that attention into the external environment, then you start to facilitate that natural self-organization of the proximal structures and the anatomy as a whole. So it actually kind of ties in nicely with this kind of attentional layer that we didn't really speak about too much. But if I have a pain experience at the lumbar spine, pain is a conscious experience. That's a good thing that it's conscious, because if it was subconscious, it wouldn't really help us change behavior. So if you have more conscious attention distributed through the lumbar spine, from an attentional standpoint, we want to distribute that attention distally into the environment. That's the end goal, to distribute that attention into the environment and not think about my lumbar spine. But we have to take steps to get there. We can't just all of a sudden say, okay, think about what's happening in the environment and let's let everything, let's let the anatomy self-organize. We need to distribute that in stages. So that's why we want to kind of move from proximal to distal into the foot and the ankle. And then once we're able to maintain that proximal anti-phase capacity, then we want to challenge that more and more. We want to add more load, more speed, and more challenges on top of that. And that's how we can help to maintain that anti-phase capacity. It's not about making sure they keep a specific position, but we just want them to maintain the capacity to express anti-phase patterns or freeing patterns. It's not that they have to do that every single time they move in the real world, but do they have the capacity to do so? That's the key distinction there.
And then one last question here, more towards talking about some of the objective assessments and subjective assessments where people have pain in that transition from sitting to standing. Bernard was saying, what's the neurology rationale of worse pain during postural transition, sitting to standing?
Well, you have to recognize that the interaction between the nervous system and the muscular tissues in a rested position. What are the task demands in that scenario? If I'm sitting down, I'm trying to rest, I want the muscular tissues to express an appropriate motor behavior to reflect the demands of that task. Okay, if my muscular tissues can't relax that muscle activity, then they're not going to have the capacity to relax, to reduce muscle activity. So that if they're always constantly working hard, if they're always expressing high levels of muscle activity, then they're likely going to be stiff or experience that sense of discomfort when they transition from rest to movement. Okay, so those are your clients that get up and it takes them a while to loosen out. So what's happening there is that when you stand up and when you move, you have to naturally distribute more load into the feet and the ankles, into the distal tissues. And theoretically, that can help distribute or redirect some of that workload into the distal tissues and give the proximal tissues a chance to relax, because now you're distributing that muscle activity instead of concentrating it at the lumbar spine. So it's all about recognizing the strategy of the nervous system's interaction with the muscle activity. Does the nervous system have the capacity to reduce muscle activity, or is the acceleration always on? Is it always expressing high levels of muscle activity to protect the area? If there's a need for protection, the nervous system only has a couple of ways that it can communicate that protection. It can communicate it through higher levels of muscle activity, through the experience of pain, for example, as well. So we're looking at that interaction between the task demands and then how that might change when we get into a standing position, because now we're putting more load into the lower limb in that scenario. So that can help redistribute some of the muscle activity and some of the workload.
Perfect. Cool. Awesome. Well, that's all the questions here. We appreciate you guys, hanging around with us on a Saturday afternoon or evening or morning, wherever you're at. Reminder about the recording. We'll get this edited up and sent out to everyone within the next 24 hours. So keep an eye out for your email. If you do not see it in your email, it probably went to spam. So pay attention to that. Check there first. And if you're having issues, then obviously you can email us. But the goal of this, again, is just to give you some ideas of how to structure your assessments a little bit differently, give you an insight into our framework. It's a lot of information in just an hour, right? If it piqued your interest and you want to learn more, obviously we have plenty of courses to offer. We have pretty huge sales coming up in the next month. So I'll put the link in the email that everyone gets with recording to some of our Black Friday sales coming up, but take advantage of them if you want to dive in with us into our level 1 course. That's where we recommend everyone starting. And obviously we take this and spread it out over 8 weeks, 16 hours. So a lot more in depth, and you'll feel a lot more confident using some of it. But don't hesitate to reach out, Instagram, DM us, email us through the website if you have more questions. Otherwise, we will see you next time. Thank you,
Thanks,
guys.
guys.
Appreciate
Thanks
it.
for listening.